now move on, if you like, to the grand finale. I can't imagine there's anybody in this room that hasn't heard of, or at least doesn't know, perhaps, David Armstrong. I first met him, I think, 25 years or more ago when he was a fellow with Larry Harkless in San Antonio. And he's had a spiraling career from there. He did his PhD with me in Manchester. Then he went back to the States. He's been a professor in Tucson. He's now a professor at the Keck Medical School and University of California in Los Angeles. And we gave him the title of predicting the future. Now, it was Oscar Wilde. He said that prediction is very difficult, especially when it concerns the future. But I thought that if anybody could predict the future, it's probably going to be David, a man of boundless energy, as I found out early in my getting to know him. It's the only person I know in the world who can answer an email before he's received the question that is being answered. And I think that you'll enjoy his presentation. He's received numerous awards, and he's going to talk to us about what does the future hold. So good luck, David.
Well, ladies and gentlemen, good morning. Bright and early here in Los Angeles, as it is in the beautiful Malvern Hills. I'm only sorry I can't be there with you this year, but perhaps next in an extreme post-pandemic situation when the only variants are strange variant podiatrists speaking to you. But anyway, great to see all of you, even virtually. And let's get this show on the road. Ladies and gentlemen, I'm David Armstrong. You already know that. And I think I'm closing all of this out by asking us, well, what should we look for and kind of what's next? And I think you've already heard from many more erudite, kind of intellectually, sartorially superior people to me. So I'm going to try to bring the quality down so everyone else looks even better. How does that sound? And by the by, we do give away all of our slides. So I would say if you just ping at me or email me or whatever you like, we just ask you to copy them, make them better, and pay it forward. How does that sound? Again, I was asked to talk about the future, but you know, we're always talking about the future, and the old story is that prediction is always difficult, especially when it concerns the future. And we're not even doing so well at the present in this. And I think our future is in measuring what we manage in companion diagnostics, companion theranostics. And that, if anything, is, you know, we need to do what we say we're already doing, as you've heard from Nicholas Schapper and so many other people over so many years. So with the next 18 minutes and 28 seconds, let's talk about that. That's really the big idea of what we're going to discuss. You've already heard how common, complicated, and costly this problem is. We don't need to talk about that. We don't have time to talk really about the history of this area in tissue repair, wound healing, and the diabetic foot, although the history is so rich in the area. Maybe next time. But we are going to just briefly talk about just the most logical aspects of how we manage wounds systematically. And then maybe for each one of these wounds, we're going to talk about efforts to measure what we manage. How does that sound? We have 17 minutes and 50 seconds left. So let's do this. That was our big picture. So first, how do we manage diabetic foot wounds, diabetic foot ulcers systematically? And then we can even go out into managing these patients into remission. But there really are three basic questions. And these questions were true in the past, they're true now, and they will be true when we finish this talk, which will be, by definition, the future, as I understand it. But the first question we have to ask, and it's kind of in this order, is what are we going to take off this wound that might help it heal? These are elements of debridement and offloading. You've already heard bits and pieces of this throughout the symposium. The second question is, what might we put on this wound that might help it heal better, faster, easier, or maybe a combination, if we're lucky, of more than one of those? And then finally, how do we increase ulcer-free days in remission? And if we're feeling cheeky, we might not just increase ulcer-free days, but maybe ulcer-free days, hospital-free days, and activity-rich days. That could be our holy trinity, seeing as we are in and around the Abbey Hotel, if we're going to be looking toward a higher power. So first bits, what are we going to take off the wound that might help it heal? You've already heard about offloading, but let's just talk about debriding. I think if we look toward the future as we measure things in the wound now and in the future, you can kind of think of a slow healing wound a bit like a slow running computer. When we're frustrated with our computer, as we often are, and by we, I mean me, often I'll look at my computer and I'll see all these things running in the background. And I think it's bogging stuff down. Maybe there are a lot of tabs open. Same thing in a wound. There are abundant data to show that these wounds are a soup, a gamish, if you will. That was Yiddish, by the way, of inflammatory cytokines and chemokines, just chewing up all of that beautiful granulation tissue before it's had a chance to do anything about it. And so what do we do with a slow running computer? It's the same thing we need to do with a slow healing wound. We really need to hit kind of, if we're talking about it being this histologically hostile environment. We had this paper not too long ago with Jeff Gertner and me and Nature Endocrinology, where we talked about this exact same thing. The analogy really is to hit Control-Alt-Delete and hit reset. And that surgical reset is something that we need to do now and we need to do in the future, but we need to measure it better. And we're going to talk about that toward the very end. But that's the first bit, what to take off, because when we're rebooting the wound, as it's rebooting, we might have precious time to apply more advanced therapies that might help the wound, if you will, boot up and heal up a little bit more consistently without all of that inflammation getting in our way and maybe helping us. The second bits include what are we going to put on the wound that might help it heal faster, easier, or better? What do we mean by this? Well, let's look. There are so many different advanced wound technologies. You've already seen bits and pieces already, even in this session. Some very exciting ones, actually, right now. I can't believe I'm saying that topical oxygen therapy is exciting, but I think these data have been really, really promising. I used to say that unless your legs have evolved gills on them, I'm not sure how topical oxygen therapy is going to work. But I'll just picking that one out now. I'll say that that's something that in the past may have not been true, but I think the data now seem to suggest that there's a real signal there. But how do we know? How do we know when growth factors are working? How do we know when we have enough receptive receptors with cell-based technologies? Again, we're going to talk about companion diagnostics ultimately. But before we do any of that stuff, we really need to simplify, not to complexify, if that's a word. It is now through the chair. And our philosophy is to eliminate as many of these technologies and therapies to get to kind of the atomic minimum. And our atomic minimum is really twofold. We really have two strategies. The first is a vertical strategy where we need to resolve depth, and that you can resolve that now by rotating tissue into the area. We think that that is coming back, a lot more tissue transfer. And we can also do it through negative pressure wound therapy. And then we can resolve epithelialization through good quality skin grafting or through other types of products that might help epithelialization just a bit faster. That's sort of the strategy. And you could see it here in this very, very kind of work-a-day sort of wound. You already see 2 piggies have gone to market there based on my podiatric assessment. But I'd just done this incision and drainage. My partner, Vince Rowe, just did a bypass dorsally. So now all we have to do is fill that thing in. We could do that with various aspects of negative pressure wound therapy. You see here, we can then add products or just heal it in secondarily through good quality offloading, like total contact casting. And you see that being done all the way through here. But how, if we were going to do something like this, do we know when to start one thing and stop another? In the past, we have been using entire visual cues. It's almost like we've been flying without instruments and only using visual cues. Wouldn't it be great if we were instrument rated sort of for the future? And that's really the big idea behind just the last few minutes of our chat today, which is really not just diagnostics, but theranostics, things that might assist us in therapy, if you will. If this, then this. Because if we don't have diagnostics that are companions to therapies, we won't have categories of therapies that really mean anything. All we'll be doing is what we're doing right now, which in many ways is just, it's it's medieval, except it's not medieval, because I think there are many medieval physicians and clinicians that probably observed things better than we did. We could do better, I think. And it's an exciting time because I think a lot of this stuff is coming together right now. So let's talk about an axis, not of evil, but of healing. And if we look at it, if we look at that, maybe in a similar way to what we did when we talked about what to take off and what to put on a wound, if we assume that this axis that we've just drawn here is a timeline, there's maybe just a few things that we can do along that timeline from open to closed. And it would be, first we need to debride the wound after we get the infection and the flow under control. We need to then promote either regeneration or granulation tissue. And then finally, we need to get the wound closed and then maximize ulcer-free days in remission with closure. And then when we're doing this, we have all these different categories of things for debridement, for offloading, for filling in the wound. Remember our vertical and our horizontal therapy. All of these things will likely change over time, but wouldn't it be nice if we can measure some of these things as we are moving forward to really not just care for the wound, but to close the wound. So this very, very busy slide is really sort of the whole enchilada, if you will. But wouldn't it be great if we had companion diagnostics at certain points in this, along this axis of healing? So let's talk about that. First, let's talk about methods to measure bacterial load and local flow in debridement. Then we're going to talk about promotion of granulation tissue and how we measure that. And then finally, closure and remission. So first, there are so many different methods like of assessing local flow and bacterial load, but let's just kind of get into this just a bit. Oh, look at this. This is a peri-pandemic picture of Professor Andrew Bolton. You see he has his kind of lockdown beard going there. It's very kind of 19th century, if you will. But then after Loretta Villakite kind of did the Loretta Villakite kind of beautician work, you saw him move from old school to new school, and that may be what's happening as well with bacteriology, and with what we are doing now with molecular microbiology, moving from Pasteur in the basement somewhere where we're plating things to CSI, where we're now doing molecular microbiology. What does this mean? Or is it just paralysis of analysis? I don't think so. I think now what we are seeing is great promise in being able to assess these wounds now in real time. You see advances here with just a very simple fluorescent device, blacklight really, that can look at porphyrins and other aspects of different kinds of bacteria, fluorescing them different colors and even fluorescing collagen different colors, so we can assess the wound in real time in a semi-quantitative way. This is what we are doing on a day-to-day basis now, before and after debridement. But what about something that's more quantitative? What about that sort of CSI, if you will? What we are seeing now is that more complicated wounds seem to have quite a lot more variety associated with them, and that variety may be able to be identified earlier on, but then moving from what we are doing now, which is just measuring these wounds, and then ultimately identifying maybe healthier kind of ecosystems, healthier wound ecology, and in the very near future, maybe even adding bacteria. What about lactobacillus? We can learn a lot from our GI colleagues or others. We've written about this now for the last 15 or 20 years. Wouldn't it be great to see this actually happen? And I think this is what is next. We are already now working with some really cool genetically engineered lactobacillus that can make some other proteins. But what about just adding that to the wound to improve our healing phenotype? Maybe. We shall see. So that's on the bacterial or end of things, on the microbiome. But what about on looking at flow? Well, there are any number of therapies that we can use that might assist us. This is indocyanine and green angiography, which we've been working with for the last 10 or 12 years. You can see it really gives you the oxygen anatomy, really everything filling in an area in real time. And you can look at the area under the curve and maybe really get an inflow rate and egress rate. This is maybe a potentially helpful tool, but what about other tools like hyperspectral imaging? This has been around now for more than a generation, but it is getting more and more accurate. We believe that some of these things can identify not only the level of flow early on, but then likelihood of healing, and then robustness of tissue in remission. So this may assist us throughout our overall regime. Let's continue on now from the bacterial load, looking into the future to other diagnostics as we look at wound healing and promotion of granulation tissue and healing. But look, we can look at not only imaging as we quantify these things to measure these wounds and predict. We can look at inflammation, and we'll talk about that very briefly, but even something as simple as wound pH. Literally a litmus test could likely give us really, really important information. And yet this is something that we have never employed as well as we could. But look at these data. For a very long time, we've shown very predictable changes in pH over the span of a wound, and we may be able to deliver something that might alter that pH to get someone back onto a healing track. Something as simple as that, along with our sort of wound vitals, may be part of our armamentarium very inexpensively in the near future. And why not bake that into the overall cost of a therapy? Other possibilities here include measurements of inflammation, as you see here. It's been around for quite a long time, looking at MMP2, 9, and elastase, this wound check device, which can be done at bedside, identifying elevated protease activity associated with poor wound healing. You see a wound surface area there on the right, but what if the MMP activity sharply dropped before the wound size started to drop? That would be a leading indicator, which might indicate that we don't need to use expensive products. The patient is about to move forward toward healing. This is the promise of very inexpensive diagnostics that we can bake into the cost of some of these very expensive therapies before we ever use them. This is another. These are other efforts that have been around now for quite some time. What if we did, just like with Mohs surgery in dermatology, what if we did Mohs, if you will, for toes? And imagine that now. Imagine assessing for receptive receptors in this patient population. And this is a way forward now in our patient population. And this is from Rob Kersner's group and Maria Tomich-Kanik, where you can assess for receptive receptors, even in advance of knowing when to start and when to stop therapy in debridement. Wouldn't that be great, instead of just looking for if a wound is bleeding? We don't have time to get into all of these other volatiles and all these other analytes for assessing wound healing, but suffice it to say, this lovely, elegant review by Tagle really gives us really a way forward and a peer into the future in some of the diagnostics and theranostics we can look forward to. And then finally, if we're talking about closure, what about looking at simple durometer? And in addition to things like thermometry, because a wound will heat up before it breaks down, and visual assessments. We've talked about the foot selfie over many, many years. You have Moy Hoon Yap, who's doing now the grand challenge to look for AI-based visual assessments of a wound that's about to happen, and then looking at depression and how we can help our patients get out of that overall funk and back into moving through the world. And that could be a diagnostic consideration as well as we move our patients forward, as half of them are clinically depressed. And ladies and gentlemen, so what we've done now is we've kind of taken a bit of a tour now through the present and hopefully the very, very near future of companion diagnostics and theranostics. But as we conclude, ladies and gentlemen, Mr. Chair, let me just go to one of my intellectual heroes, and I know yours. Look at this guy. And just say, Albert. And that's what he's doing here. And but when I think about great pithy quotes, you can just rely on Professor Einstein. And when he was talking about measurement. He said, not everything that's counted counts, and not everything that counts can be counted. Try saying that 10 times real fast. But the bottom line is this. Right now, what really counts is what we are not counting. And it is really figuring out better ways to measure what we manage. And if I could wish for anything in the very, very near future, it would be that, because we are never going to have these categories of therapy. We are never going to have a vision for the future until that happens. But I'm more confident than ever that we're seeing this happen. And as we move through the future, whether it's real or virtual, I think this is one that is enormously promising. And hopefully we're going to be healing a few more of these patients, keeping a few more legs on a few more bodies, and helping people move through the world a little bit better. Because I think that's what we all deserve, whether we have diabetes or not, and no matter what our health, and no matter what our age. Mr. Chair, Messer's Chair, ladies and gentlemen, thank you so much.